Self-Directed Learning module. Welcome. My name is Daphne Broadhurst. I'm an infusion nurse specialist. At Ontario Medical Supply and medical pharmacies, we are committed to providing professional development opportunities and quality education supporting the therapies and supplies which we provide for home infusion therapy. We're going to demonstrate how to successfully change a patient's PICC dressing. You'll learn how to remove and apply the 3M IV Advanced Securement dressing. The video demonstrates aseptic no-touch technique. However, we will describe in audio when to don sterile gloves for agencies adopting the sterile technique procedure. The purpose of this selected securement dressing is to protect the site and stabilize the catheter, which is now the standard of care. How often should the dressing be changed? Transparent film dressings are changed weekly in PRN if it's contaminated, damp, loose, or visibly soiled. A dressing with compromised integrity has been shown to increase the risk of catheter-related infection 3 to 10-fold, as demonstrated by Dr. Timsett's study in 2012. So let's prepare our patient. You will have, of course, introduced yourself to your patient and verified their identity. Explain the procedure, ensuring they understand the purpose of the procedure and that they're agreeable to the procedure, which will help increase the patient's comfort level with the procedure. It's important that you take the time to make sure the patient is in the appropriate position, or you'll be setting yourself up for failure and will likely end up contaminating the site. Position the arm abducted in a 90-degree fashion, so away from the body. If the patient is sitting up, ensure that the arm is well supported, such as with a pillow. Have the patient turn the head away from the site and consider masking the patient if he's coughing. Next, and this is the foundation of the nursing process, is the patient assessment. Before starting the procedure, you must assess your patient's response to the therapy. Assess for signs of PICC-related complications through visual and palpation inspection. Are there any signs of venous thrombosis? Is the arm swollen or tender? Is there any swelling of the face, neck, or eyes? Look at the patient's upper arm and chest. Are there any collateral veins, those smaller veins that are now distended as they have to accommodate the disrupted blood flow due to the thrombosis? In your assessment, do you see any signs of infection? Is the site reddened, tender, swollen? Is the upper arm swollen? Is there drainage? Is there fever, chills, weakness, hypotension? If you suspect site infection, you should make arrangements for the site to be cultured as per your protocol. Are there any signs of CVAD-associated skin impairment? Is the skin reddened? Are there any macules or papules? Any drainage? You're now ready to gather your supplies, don your mask if that's in your protocol, wash your hands, gather your supplies. You need a pair of non-sterile gloves and a pair of sterile gloves if doing sterile technique, or a second pair of non-sterile gloves. You may use a sterile drape if it's within your protocol. Sterile gauze, again, if that's your preference. You need your skin antiseptics. We use chlorhexidine with alcohol swab sticks. You need one stick at least to perform the skin antisepsis, and a second stick if the skin is soiled. If the patient is sensitive to chlorhexidine, you can try the chlorhexidine swab stick without alcohol if it's available, or if not, then try povidone. You need your dressing. The IV Advanced 1685 is what we use for PICCs. You need your skin barrier protectant, which we use prophylactically on all our PICC dressing changes. You may need a swab to culture the site if you suspect an exit site infection. If you're changing the caps, you'll need your needleless connector, 1 per lumen, such as your Max Plus or your microclave, which we use in this area. You need your pre-filled saline syringes and alcohol swabs, as well as an extension set if indicated, particularly if the client's doing any self-administration of infusion therapy. Attach the pre-filled saline syringe to the needleless connector and prime the connector. Leave the syringe attached to the connector so you can flush with it later on. If the PICC is open-ended without a valve, close the built-in clamp on the catheter. If there's an infusion running, you need to stop and disconnect any infusion that's present if you're changing the caps. So now we need to remove the dressing. Wash your hands as per your protocol and allow them to dry. To remove the dressing, peel off the date strip. You can use this strip to secure the end of the catheter to prevent the catheter from dislodging during the dressing change, although you might find it easier to put this strip on in a few minutes after you've removed the next strip. So now let's remove the large strip. Pull it down towards the end of the PICC. please don't peel it upwards towards the exit site or it'll get jammed up. So peel it down away from the site. And in this clip, it would have been much easier to remove the strip if that date strip hadn't been applied yet. And if you haven't applied it, now's the time to either use the date strip or piece of fresh tape to secure the ends of the catheter to avoid causing catheter dislodgement. Now you need to remove the bottom part of the dressing. Separate the two edges at the base of the dressing. Lift one side up to the clear part of the dressing to expose the catheter wing. And you may want to tab that edge of the dressing over so it's easier to pull. Now lift the other side, peeling it back to the clear portion of the dressing, to the wing. To remove the rest of the dressing, stabilize the wings of the catheter with your non-dominant thumb, or if you like, you can use a sterile gauze between your thumb and the wing of the catheter. So hold that catheter down. Grab the folded tabs of the dressing together in one hand, fold it back over, parallel to the skin, and roll it back smoothly towards the site upwards to remove the dressing. Don't lift the dressing up, or you can stretch the dressing and the skin, causing discomfort. You may actually pull the epidermis and cause it to separate from the dermis, effectively stripping off the top layer of skin, leaving irritation similar to a first-degree burn sometimes, as manifested by reddened or shiny skin. Remind your patient not to move his or her arm at this point. It's crucial that that catheter is not dislodged. You need to measure the external length of the catheter from the exit site to where the hub begins. We do not include the hub or the wings in the catheter measurement. So in this image, you can see the black dot. Each dot represents 1 centimeter, so our external length here is 1 centimeter. That's the length of the blue portion of the catheter that's exposed. We need to compare that length against the documented length to see if any catheter dislodgement has occurred. And if there has been dislodgement, never push that catheter back in, never re-advance it, or you could be advancing skin microbes as well and putting your patient at risk of a catheter-related infection. It's imperative that that catheter remain in the original position. If the catheter does become dislodged, the client's at risk of the tip now being in a smaller vein, irritating that vein and causing thrombosis, extravasation, or venous stenosis. We're now ready to clean the skin and defat the oils in the skin so the dressing adheres. Again, inspect that site now that the dressing is off. To cleanse the site, we use one stick to clean the catheter and we use another one to clean the skin. That's not necessary if it's not in your protocol. However, if the skin is soiled, you do need to use a separate stick to clean the skin, and then your subsequent sticks will be used for the antisepsis. Now you can see how large the dressing is. You need to clean just beyond the area of the dressing. Cleanse the site with friction in a back and forth or hashtag pattern, taking care not to dislodge the catheter as you're cleaning with the swab stick. With friction, scrub the site in one direction for 15 seconds. Here we're rotating the stick so it butts up against the catheter to better clean the area, but note we haven't yet flipped the stick over. Clean the other side of the skin of the catheter for another 7 seconds. Then you flip that swab stick over and scrub in the opposite direction for 15 seconds. So now we're going to go horizontal. The friction allows the chlorhexidine to penetrate the 5 layers of the skin where the microbes are harbored. You need to really scrub, clean it like you mean it. And if you prefer, you can use a sterile gauze to gently pick up that catheter off the skin to clean underneath without dislodging the catheter, of course. It is crucial that you allow the skin and the catheter to dry completely to allow that chlorhexidine to bind to the skin to increase antimicrobial activity. You need a minimum of 2 minutes with the chlorhexidine with alcohol, or longer if the skin is moist or oily. If you're using the chlorhexidine without alcohol, that can take much longer, sometimes 5 to 8 minutes. If you don't let it dry, the dressing may not stick and it can cause CVAD-associated skin impairment. Do not blow dry or fan to dry. Note that if the site is hairy, please clip the hair to promote adhesion of that dressing and therefore securement of the catheter. At this point, if we suspect infection, we would swab for culture and sensitivity. Now, while the antiseptic solution is drying, if you wish, you can use this time to change the needleless connectors, which we'll demonstrate later in the video, although you'd of course have to make sure that that catheter is well stabilized and the patient isn't moving their arm to prevent the risk of dislodgement. So now the skin's clean. You can remove your dirty gloves at this point, wash your hands, and either don sterile gloves if that's your protocol or non-sterile gloves if you're doing aseptic clean technique. To prevent the risk of CVAD-associated skin impairment, we routinely prep the skin with a skin barrier prep. This film acts as a protective interface between the skin and the dressing adhesives. It's also particularly useful for diaphoretic skin to to act as a barrier between the dressing and the moisture. Ensure that you have a sterile skin protectant that's compatible with chlorhexidine and avoid alcohol-based products. The manufacturer of No Sting, which we use, has confirmed that the film is compatible with CHG. To apply the skin barrier, start on one side and paint the area where the adhesive will be in one direction, preferably not going back and forth over it. You don't need a thick layer, it's going to take longer to dry. It does dry quite quickly though, usually in about 30 seconds, so let that dry before you apply the dressing. And set the wipe aside, you're going to use it later. So our site is now clean and dry. We're ready to protect the site and secure the catheter by applying the dressing. How you apply and remove that dressing is crucial to successful catheter outcomes to prevent skin injuries such as skin tears, skin stripping, and contact dermatitis. So let's remove the back liner of the dressing. Hold on to the non-adhesive wings of the dressing, or the ears of the dressing as some like to call them. There's no adhesive on these tabs, so your gloves don't stick. Avoid, though, touching the dressing where the adhesive is, as this should remain sterile. The dressing should be placed so that the white border between the dressing window and the white soft cloth should sit on top of the winged hub of the catheter lumen to maximize stabilization of this catheter. If you want, you can remember white over the wings. The wings should not be visible through the window. To place the dressing, it's actually best if you bend or U that dressing so that there's no tension on the dressing, so you're not stretching it as you place it down, in which case, if you do stretch it, when the dressing returns to its normal state, it pulls this underlying skin back with it, potentially causing CVAD-associated skin impairment. So you place the dressing in a U shape, hover over the site so that the border between the window and the white tape is over the wings of the catheter, and drop it so that the white border of the dressing is over the wings of the catheter. Now press with your thumbs down on the window to mold the dressing window around the catheter. You don't need to press the white part of the dressing yet. You can see the white soft cloth of the dressing is over the wings. Now we need to secure the base of the dressing. So you can lift off any tape that might be securing the legs of the catheter. Lift the paper edge of the dressing, moving the catheter up out of the way. Lay this side down on the skin, not stretching it. Lift the other side of the cardboard paper. Lift the catheter leg out of the way and press that dressing down so it just kisses or just meets the other side of the dressing. You don't want to pull on it to avoid any tension. Peel off the cardboard dressing frame, slowly pressing down on the dressing with your other hand as you peel off the border. It's important to really firmly press that dressing down as you remove the border to ensure that you get all areas of that dressing adhering to the skin. Again, firmly press down all over the dressing to make sure that the adhesive gets into the nooks and crannies of the skin. Now you need to add the adhesive strips. Grab the large strip and turn it upside down so you can see the tabs. Grab the tab and pull off the liner from the paper. This piece fits under the lumens, so lift the lumens and slide the strip up as far as it can go and butt it up against the wing of the catheter. You can lift it and reposition it if you need to. Always remember to remove the paper tabs and press down the dressing so that it is firmly secured. On the date label, put the date, your initials, and in our area we also mark what the external length is, so if the patient goes into the clinic or into the hospital, they'll know what the external length was. Place the date strip over where the lumens are coming out of the dressing, so you pinch it around the catheter lumen, or if you have multiple lumens, you can press down between the lumens to add to the security. And here you can see we're looping up the end of the catheter to help secure. Remove those paper tabs on the strip. Avoid putting any tape over the clear window of the dressing. We'd also recommend now take your protective barrier film and rim the dressing, running the film over the edge of the dressing and the skin so that it helps to secure the edges and prevent edge lifting. In the community, the needleless connectors are changed at the time of the dressing change or when blood or precipitates are present. If the PICC is open-ended, close the clamp on the catheter. You can hold the distal end of the catheter with a gauze. Scrub the connection 30 seconds with an alcohol swab or preferably with a chlorhexidine swab stick to avoid touch contamination of the exposed catheter hub. Allow to dry. Remove the old connector. In the video, the nurse did not cleanse the threads of the lumen, but we recommend cleanse the lumen threads with an alcohol swab, avoiding contact with the interior of the catheter lumen, and allow to dry. It is critical that you do not touch the open end of the catheter hub to prevent contamination. Attach the prime connector by grasping the connector rather than the syringe as seen in the video and screw the cap on. Change the caps of any remaining lumens. It is the nurse's responsibility to verify that the catheter is functioning optimally to ensure our patients are getting their prescribed therapy. In continuing your catheter assessment, you'll now need to check the patency of the catheter to determine that there are no signs of a catheter occlusion or blockage. Do you have prompt blood return? And is the catheter easy to flush with saline? Pull back on the syringe plunger to aspirate each lumen to verify blood return. If there is no blood return, this needs to be investigated to prevent further complications. It's imperative that we make sure that we don't get a buildup of fibrin or blood cells within the catheter lumen, so we now need to flush the lumen as well to verify patency. Flush each lumen with 10 to 20 mils of sterile preservative-free saline using a turbulent flush technique, or that push-stop motion. If there is an order to lock the catheter with heparin, lock the catheter with heparin. Although emerging evidence suggests we should be moving away from the use of heparin to lock our catheters due to the risk of heparin-induced thrombocytopenia. You're now nearing the finish line. Be sure to anchor the extension sets and tubing to prevent dislodgement. Remove your gloves, wash your hands, document the date, the time, the procedure, the external catheter length compared to the original length, the condition of the site, any specimens obtained, and any patient teaching. Successful outcomes are also dependent upon the patient's care of his or her line. The nurse must educate the patient to understand their responsibility in caring for the PICC, its dressing, and any equipment related to the infusion. They must understand the signs and symptoms of complications, what to report and to whom, and more significantly, how to avoid complications through appropriate care of the line. Discuss any activity restrictions related to the catheter. The clients need to be taught what to do if the infusion pump alarms or stops functioning if they do have a pump. To validate the teaching, the patient and or family should be able to verbalize or demonstrate their responsibilities in caring for the line. And this concludes our program. We hope this review has provided you with both the knowledge and skill that will benefit both you and your patients as you strive to deliver excellence of care in infusion therapy. I'd like to thank Heather Bozick, Nursing Supervisor at WeCare, for helping produce this video. Thank you.